Hello everyone, my name's Joe Cuthbertson. I'm a member of the Board of Directors for the World Association of Disaster and Emergency Medicine. And today we are taking on the first of our PDM podcasts. We're looking at an article recently published by Assistant Medical Director, Community Emergency Physician for over 10 years, Casey Patrick. Welcome, Casey Patrick.
Thanks everyone. I'd like to start off by thanking WADM and PDM for having me on to share our research, and hopefully it's a useful discussion and will generate some further thought and questions, and will be of interest to all the listeners.
Brilliant. Thanks, Casey. So at a personal note, I've been a paramedic for 20 years and I was really interested to read this article. It looks into the use of bolus dose epinephrine in hypertensive patients in ground-based EMS, something that's close to my heart and many of the readers of PDM and members of WADM. Can you tell us from your perspective, Casey, what got you into this study and why it was of interest to you?
Well, before we get too far into the details, just a little bit about our service. I'm the Assistant Medical Director for Montgomery County Hospital District in the northern metropolitan area of Greater Houston. Montgomery County is the county due north of Houston proper, and we have about 750,000 residents, about 1,000 square miles, and Montgomery County Hospital District EMS does all of the 911 EMS services for the county. And we have an amazing EMS service. We have tons of community support. Our administration, our clinical department really asks for us to be, advanced and to provide the highest quality care to our community members. And this is something that, has been a fairly prominent topic in the emergency medicine sort of phone sphere. The blogs, push dose pressors have been something that's kind of been on the forefront of conference discussions for 4 or 5 years now, but the actual literature support is thin relative to some other areas. And this really was a treatment that what we found as the medical directors was that our advanced and higher performing paramedics in the higher ranks were doing this off book. And the reality is that when you're in a home, you're in an apartment complex, you're on the side of the freeway, and you've got a crashing patient, you're attempting, airway management, for example, you don't have the wherewithal, you don't have the time at that point to spike and set up a vasopressor drip. And, our medics they listen, they learn, they're reading the same blogs and following the same, prominent EM foam folks that I am and that you are. And they were using push dose pressors. We knew it. And it was something that, I use in my own practice. So it's hard to necessarily get too upset, but like everything else in EMS, we want our protocols to match best practice. We want our protocols to allow the medics to take care of the patient in the best way possible. So this really was sort of a retrofitted protocol that we wrote to allow the medics to, for the most part, do what they were already doing. So the protocol portion of it was a little bit backwards. The research side of it was more to look and see, okay, we know this is something that we're doing. Is it safe? There's not a ton of literature out there, especially in the EMS, in the ground-based space specifically, of what happens to these patients when they get push dose pressors. Do we get a response? Do we have a ton of hypertension? Do we have arrhythmias? So really it was a protocol written to allow us to do what we were already doing. And it was research to look at, what happens to these folks and can we do this safely in the truck, and is there a role for this? And realistically, it's a single service study and, relatively small numbers, all the limitations that we talked about in the paper, but we've got to start with small bricks to build the foundation, and so that was really the impetus for the study.
Brilliant. That's great context, Casey. You've really outlined how you've seen this gap in care. Well, the care was being addressed, but you've identified that there's a need to build on that evidence base. Tell us about the study itself and what the mechanics of it were based on, what you've seen contextually within the service to drive this research.
So we're a community-based third service, EMS outfit. So we're not directly academic affiliated. So we don't have a ton of, we don't have statisticians on staff. We don't have research fellows. We don't have EMS fellows for that matter. So realistically, we have to take our research in small bites because it's number one, not our primary focus. Our primary focus is on the community, but it's also if we take on too much, it's just too hard to manage. So the study basics really are retrospective. We rolled out this protocol. We decided that it was, we had enough evidence based on, the ED literature, based on ICU literature, some other areas where, bolus dose vasopressors are used in obstetrics and in the intensive care unit in the pediatric world. We felt like this was standard of care. So we rolled the protocol out, and then we said, okay, we're starting this. Now let's see what happens to these patients. So let's set a date on the calendar and let's collect all the charts over that year, and let's look at, what does their blood pressure do? What does their heart rate do? Why were we giving it? What's the patient population look like that gets this treatment? And realistically, we modeled this after some other EMS studies that were actually just recently published in prehospital emergency care. There's a couple from University of Pittsburgh that were looking at this similar issue a little bit differently in critical care transports, helicopter EMS situations. So there wasn't a lot out there, if anything, using this treatment in ground-based EMS. So the realistic basics were, a retrospective look at patients who got push-dose vasopressors in our ground-based service. The other sort of caveat, the specific group where we changed it up just a bit, and part of it was logistical, but part of it was it's the patient group that we looked at. And, we give a lot of, if you look at our inclusion exclusionary flow chart, which is figure 2 in the manuscript, we excluded all of the patients who presented in cardiac arrest. Now that one might say, well, that killed your numbers, and it did. We would have had a much more robust end number if we had kept the cardiac arrest. But realistically, in my mind, and I'm sure some could argue with this, but I feel like using push dose pressors, peri-arrest, post-arrest is an entirely different patient population from a treatment goal standpoint, as opposed to the patients that we included. And those were the patients who presented in a hypotensive situation. And we decided to just include general hypotension, non-arrest patients, because we're already using epinephrine in some form or fashion in the ACLS protocols in all of our peri-post-arrest patients. But we're not really always using, at least I wasn't until the advent of this treatment and kind of the push for using bolus dose vasopressors in just the general hypotensive patient. So I wanted to see what the patient population looked like and how these folks responded. And in all honesty, the other piece of that puzzle was logistically, collecting retrospective EMS chart data that's remotely accurate from the peri-arrest, post-arrest patient gets really muddy and murky. So from just an ease of publication standpoint and ease of data collection, this group was a lot easier. They had a lot less holes in the charts than those peri-post-arrest patients. So that's kind of where we started with the research end. The protocol end, for folks who are interested, we kept it fairly simple. We tossed around different vasopressors before we rolled this out. I was sort of pro norepinephrine or noradrenaline at the start of this discussion. There's some phenylephrine papers out there. There's some folks who use push dose vasopressin in the end, we already have epinephrine in every single bag, on the truck. It's around us 100% of the time. The paramedics are familiar with dosing, familiar with the packaging. So we elected to stick with epinephrine really just out of ease. So we weren't introducing a new medication with a new dose. I mean, we don't carry norepinephrine on the trucks. I'm, in the actual cardiac arrest bag, it's in the truck and we use it. But as far as it being present on the scene, that was going to change some of the way that the bag was arranged and some of the ways that the paramedics carried our medication. So in the end, we decided to push dose epinephrine on the scene when you're taking care of the patient initially as a bridge to that norepinephrine or epinephrine drip once you're back in the truck where your entire, gamut of pharmacology exists, as opposed to in that bag when you're on the side of the freeway or you're in the trailer, you're in the apartment complex or the home where you've got that epinephrine that's always there. And we used, 20 microgram doses. So we took 1 mil of 1 to 10,000 cardiac epinephrine and mixed that with 9 of saline and used 2 milliliter doses, which gave 20 micrograms. And that really was, we just set it up to where systolic less than 90 was our indication. We didn't really want to get too much more complicated than that. We tried to make it as simple as possible. And that really was the way that the protocol was set up. You can see that in the article, and that's figure 1 is our actual protocol copied into the manuscript. So that really is kind of the basics there. If you want to delve into any of those details, feel free, and we can talk about those further or move on to some of the additional questions.
Thanks, Casey. What really strikes me about what you've sort of outlined there, and in fact the article as well, is how you've really contextualized practice into this research. You've got a really clear understanding of the needs within the field and understood them when you've looked at this research. One of the questions I did have is, what would you mind outlining for us all some of the risks associated with push dose epinephrine?
Well, if you look at the existing literature that's out there, I mean, the big concern is going to be arrhythmia and potential hypertension, and you see, low rates of both of those in some of the studies that we used in our bibliography. So we were, concerned about, can the paramedics administer this without us having blood pressures, pop off and episodes of atrial fibrillation or SVT or even, ventricular tachycardia. And so we were, me personally, I was really surprised that we didn't see a lot of downside. That's what we were looking for. I reviewed every one of these charts personally with my cardiac arrest coordinator, Brad Ward, who's sort of my right-hand man in most of these cardiac-related studies that we do. He's the second author there. This paper wouldn't be in existence if it wasn't for Brad's hard work. So I've got to give him his kudos before we get too much further along, or he's going to probably whack me in the back of the head. But that's really what we look for in every. Again, we comb these charts with really a fine-tooth comb, looking at the monitor data and the 12-lead data and the narrative that the medics wrote, and looking to see, did they, what did the vitals do? What did the heart rate do? And realistically, I mean, the heart rate stayed very stable. It actually, stayed almost exactly the same, if not a slight decrease in heart rate. We did see one patient whose blood pressure really jumped up with the push dose epinephrine. And that was concerning, and we've continued to watch that really post study, and we've not seen many more of these. But the patient was clearly hypotensive, and when we saw that blood pressure jump, I thought, okay, did the paramedics get a spurious value and give the medication a little too quickly? Was this one who had a 78 over 68 that was an incorrect read by the mechanical blood pressure monitor? And looking back at the chart, I mean, the patient presented clearly with clinical signs and symptoms of sepsis that looked, the history and the past medical history and the patient's age and comorbidities all really fit, septic shock very, very clearly. And the first 4 blood pressures were all less than 80. So it looked, looking at the black and white, it looked like one I would have definitely administered push dose vasopressors to as well. And for whatever reason, the pressure popped up, and don't have a good explanation. The reviewers asked us about that, and we don't really have a good answer other than from a clinical significance standpoint. The patient's blood pressure settled out very nicely without any additional treatment. Epinephrine, obviously short acting, so especially in a bolus dose form. So the patient was able to settle out, and there was no reported chest pain in the chart. There was no additional 12 lead EKG or even obtained, or any change in heart rate or cardiac rhythm that went along with that. So from my standpoint, it's something that definitely, if you're going to initiate a protocol like this, these are the things that you have to be set up to watch for, because if you're going to initiate something that's new or advanced, you have to be on the watch for the expected complications. But in all reality, we didn't see those. The other issue was dosing errors. There's a lot of sort of back and forth in the emergency medicine literature about dosing errors and basically the capacity of emergency physicians in a busy ED to mix and dose push dose pressors themselves. And I think really that's a separate discussion than what we're dealing with in the pre-hospital setting, because in all honesty, our paramedics in our service have markedly more experience mixing and dosing medications than I do as an emergency physician. That's oftentimes a task that nursing takes care of for me. In some emergency departments in America, we even have, emergency pharmacists. A lot of my community shops do not. But nonetheless, I feel like comparing what I do in mixing medications and administering them to what a paramedic does is really not an apples to apples comparison. So I didn't feel like the dosing error argument held a whole lot of water, because our paramedics mix and dose medications all day, every day, and they're comfortable with that. So I thought that was a little bit of a non-starter. That being said, we did have a medication error that we tossed out of our analysis, and it really did shine a light on another issue that unfortunately that we all often deal with in emergency medicine and EMS, and that's medication shortages here in America. And we could go on for probably hours talking about the issues with medication shortages and the complaints and the issues that exist there. I will stay away from those, but just for discussion's sake, just touch on the fact that we ran out of 1 to 10,000 cardiac epi as far as being able to source that. So we changed our epinephrine stock to 1 to 1,000. When that happened, we made the necessary changes from a stocking standpoint, but we didn't do any alert or any direct patient or direct provider education on, hey, we switched to 1 to 1,000 in the push dose protocol. This is going to change your mixing and your preparation steps here. And so we had a patient that got 100 micrograms or 200 micrograms, I should say, of push dose epinephrine, as opposed to the 20, an order of magnitude higher there at 1 to 1,000 as opposed to 1 to 10,000. And thankfully that patient had no untoward outcome, and vital signs were all stable, and the patient had no complications. So it ended up working out okay in the end. And looking through some of the literature, we were able to, even find some studies where that 100 microgram, 200 microgram zone was actually the starting dose for some of the critical care transport services. So, you know, in these super sick patients, giving them 100 to 200 micrograms of epinephrine is not, you know, earth shattering by any means, but that was definitely an issue that we ran into. And we just went back in and made a protocol addendum that added a bullet point to describe the administration of you know, push dose epinephrine with 1 to 1,000 as opposed to 1 to 10,000, and didn't have another dosing error issue. So that was our single medication error that we had. And I think it brought up a good point that if you change your concentration in your stock, you know, you need to, you know, we learned a lesson there that, you know, we need to go through and find each protocol that affects and make sure that we, you know, educate on that, you know, proactively as opposed to retroactively.
It's a really good point, Casey. You know, like lessons learned are important across medicine, and it's good to hear that these are brought out even through the research process as well. And speaking of that, like when you look back on this particular piece of research, what do you think are the big take-home points that you identified that you really want people to be aware of when they read through this paper and reflect on it?
Well, you know, again, the numbers were small. I wish we had, you know, some statistical significance and some mortality numbers, and you know, everybody wishes they have those when they you know, delve into the research process. But the big picture things that I thought were the really interesting points were, you know, this was a super sick population. You know, we had, you know, altered mental status and respiratory failure really encompassed the majority of the patients. So that's the patient populations that, you know, from our experience that you're going to be using this medication on, which makes sense. You know, you're going to be using it on primarily septic patients and patients that you're, you know, preparing for, you know, delayed sequence intubation or medication assisted intubation, because we know that hypotensive episodes in both of those patient groups, you know, are detrimental for their morbidity and mortality. So if we can, you know, prop the blood pressure up before we administer paralytics, if we can prop the blood pressure up as we're bolusing crystalloid in that septic patient, as we're getting them to the hospital to get their antibiotics and to get their source control, then presumptively their outcomes are going to be better. But seeing it in table form and looking at it and saying, okay, you know, 85% of these patients were altered mental status or respiratory failure. That makes sense. You know, a large portion, you know, almost 40% were administered push dose vasopressors associated with their intubation. And, you know, that's a concept and a paradigm that even in, you know, 15 years ago when I was in residency, wasn't something that we looked at under a microscope. So I really feel like that's a positive evolution of care there, in that we're not pushing, you know, paralytics and sedatives in patients with pressures of 60 anymore. We're stopping, you know, as an EMS service, and we're getting IV access, we're bolusing fluids, and we're, you know, using vasopressors to prop the patients up so that they're not, you know, losing their entire vascular tone and you know, spiraling down into that cardiac arrest, that peri-arrest state with our treatment. You know, we don't want a iatrogenic arrest, you know. So looking at who got the medication was really probably the most enlightening part for me. And secondly, seeing the blood pressure bump and seeing that yeah, when we gave, you know, push dose vasopressors, the blood pressure did increase. This works. Now, that's not a patient-centered outcome, right? That's just the blood pressure number. And does that help the patient? Does that improve their morbidity and mortality? We don't know, but that's the first step to getting there. You know, the hypothesis is you're going to have better perfusion and less of those peri-arrest, cardiac arrest episodes if your blood pressure is 90 as opposed to 65. So seeing the positive blood pressure jump was really encouraging. And then a couple other little things, you know, half of these patients were continued on a vasopressor drip. So from that standpoint, you know, from a logistical protocol standpoint, we rolled this out for that reason, you know, so that when the patients were on the scene and the medics were on the scene and they didn't have access to the norepinephrine that was in the truck and the tubing that was in the truck, and we're lucky enough to carry IV pumps, so the pumps weren't on the roadside, so they can't set up a drip. We have a bridge, and that's the push dose vasopressors to act until we can get the patient loaded and stabilized, and then we can set up the drip. And so, half of the patients in the population were eventually transitioned to a drip. So that was definitely encouraging. And then lastly, these patients did get a pretty significant amount of IV fluid, and the concept of filling the tank and not flogging an empty tank with vasopressors is definitely taken a turn from when I learned pressor therapy, back in 20 years ago. It was sacrilege to give any vasopressor at that point prior to an exhaustive fluid bolus. And I think we've learned that that's probably not 100% the case, but I was trained in the days of leave a fed or leave them dead, and now we know that norepinephrine is definitely our friend, and we need to at some level fill the tank. We probably don't always need 30 cc's per kilogram of crystalloid for every single patient. That seems to not be a good idea. But the concept of bundling care with these patients and making sure that we've got access and that we're starting fluid and that we're doing more than one thing at a time in these complex patients. As you can see, we were able to give these patients upwards of, on average of over half a liter of crystalloid. And in our service, our transport times are in that 20 to 30, 40 minute range. Some of the scene times were a little bit longer in these folks just because we were managing airways and placing IOs and doing those sort of things. But getting in that much fluid over that time period was really encouraging.
That's great. Thanks for that, Casey. So you started this session talking about laying the bricks, which is a really good sort of segue into maybe outlining from your perspective whether or not you see this research evolving any further, and if so, what that might look like.
So obviously, any researcher would love to have large N values and randomized groups with mortality as your endpoint. So talking pie in the sky, it would be excellent to have a group of intubated patients with standard care and a group of intubated hypotensive patients that receive push dose epinephrine or another push dose vasopressor. But we just we don't have the people power at MCHD EMS to put something like that together. So realistically, speaking of small bricks, the people that do have that capability and do have that workforce available, to push these projects and to push these research ideas through various IRBs, to do a retrospective look like we did, it's not terribly difficult to obtain a waiver because we're just looking backwards at charts. But when you're going to do a prospective look, you need the small bricks in place so that you can support your prospective plans. So it would be awesome to see somewhere a multi-center study, a multi-service study, an international study, for example, that looked at multiple EMS services to tease out some of the obvious biases that are here in ours, right? This is just MCHD EMS. It's just Texas. It's just the United States. So is it applicable to you guys in Western Australia? Is it applicable to, the Northeast in America? Is it applicable to an EMS service in another state with different, EMS protocols? And the answer to that is we don't know. So there's tons of ways that this research could go, whether, moon steps, or baby steps or somewhere in between, where this could be, further investigated. And realistically, the amount of literature that's out there is there's not a ton. So there's a lot of room for folks who are interested in this. And I know there's, the folks at the University of Pittsburgh here in the States. I know that there's some critical care transport services in Colorado that are working on similar, but varied looks at push dose vasopressors in EMS. So there's other people out there that are doing this. Hopefully this small brick will help somebody along the line, either A, prod them to consider this for their service, or B, give them research support, give them some, some real data, black and white support to take the next step. And I think some of that's being realistic about what you can accomplish where you are. And I would love to be a part of a randomized blinded study that looked at mortality one day. But at my current position and current role at MCHD EMS, my focus is on educating our paramedics and taking care of the community, with research just being a sliver of that. So I'm going to have to lay the small bricks. Our services are going to have to lay the small bricks, and let someone else take the lead there. So hopefully some of the listeners out there, some of the readers of PDM will find this useful and be able to take those next steps.
It's an exciting prospect, and it's great to see you starting this journey, Casey. If looking back on what you've managed to achieve so far, if there are other services out there that were looking to step into this area, would there be any advice you'd give them, given what you've learned so far?
Yeah, I think the big one we probably touched on was proactive with any concentration changes and variations in epinephrine supply. That was our medication error that we found, and I would definitely proactively be on top of that one if you're gonna roll out an epinephrine push dose vasopressor program. Educating your medics up front on the various concentrations and how to mix 20 micrograms and 2 cc's. Not that our paramedics wouldn't already know that if you ask them in a controlled environment, but when you switch what their known is without a heads up, anybody's gonna have the potential to be fooled there. The other portion of this that was really important looking back was the education portion to basically lay the foundation for the protocol. And that really is, the protocol is just part of it. The other piece is, what do these patients look like? Who are we giving this medication to? And realistically, these are patients with shock. And it's, in the EMS situation, most of the time it's going to be undifferentiated shock. So a large portion of this study, which only merited a few sentences in the actual manuscript, was that education portion of, what are the types of shock and how do vasopressors work? And, what's the receptor differences between the various vasopressors, and what's the clinical differences between the various types of shock, and how are we going to approach these? What are they going to look like when we see them on the roadside or in folks' homes, in reality, so that the medics have a physiologic idea and a pharmacologic basis of the what and the why. I really think that's very important for paramedic buy-in. It's important for buy-in from me as an emergency physician. Someone can hand me a new treatment, but what patients are we using this in? How does this work? And I don't think it goes as far as everybody becoming an adrenergic receptor biochemist by any means, but to know what vasoactive properties and what cardiac properties that these medications involve, and what the patient's vital signs and what's going on physiologically when we administer these medicines. I think that's really important, an important component to get medic buy-in. So the education piece is really important. So I think that those would be probably two of the big picture points. The other issue is that I don't think we should underestimate how much self-learning and self-directed education that the younger medics, especially, and the older medics, I shouldn't single anyone out, but, all paramedics really are doing on their own. And a lot of our folks are listening to podcasts and reading blogs and really, taking the education, personally and seriously. And so this concept is out there. Paramedics know about push dose vasopressors. They know that it exists. So I would say if you're rolling it out in your service, you probably already got some off-label, quote unquote, use of push dose vasopressors. So that kind of helped us in that we went to our high performers and some of our more advanced paramedics who, were our leaders in clinical practice and just said, hey, are you guys doing this? What's it look like? And realistically, we took feedback from our own medics on how to proceed forward on how they were already doing this. So I would say, as much as that's not the normal progression of protocol development and rollout, we got some pretty good feedback from our medics before we even started writing it down.
That's some really great reflection there, Casey. We've come to the end of the podcast. I really want to thank you and thank the paramedics and technicians out at Montgomery County in Texas for engaging in this trial and developing this research. It's really valuable for all of us, and thank you for publishing it in PDM and with Wadham. And thanks for your time today talking to us and explaining, what's going on behind that paper and what brought you to bringing it out to publishing it and sharing it further. So thanks again for your time today, Casey. I really appreciate it.
Thank you, Joe. And before we close up, I'd be remiss if I didn't just mention some of my other co-authors here. Jordan Anderson was the clinical chief at MCHD, led a lot of the protocol rollout, the protocol, basically writing the protocol and editing it. Joe Fioretti did a lot of the data collection and some of the IT background and finding these patients and finding these charts and helping gathering them. We had some help from Baylor Emergency Medicine downtown here in Houston with our IRB submission, and that's Kelly Rogers-Keene. Carrie Aubrey is a now staff emergency physician. She was a resident at the time, but she's out on her own and practicing independently now, and she did all the bibliography work for me and really did an excellent job summing up this literature. And then Rebecca Cash and Ash Panchal at the National Registry of EMTs here in the States helped out with the stats and some of the manuscript preparation and the structure of the study, and we really couldn't get it done without them. And then lastly, and for sure, probably most importantly, is my medical director, Rob Dixon, who puts up with my crazy ideas all the time and is able to filter those down to the craziest get tossed out. And ones like these where he does an excellent job of picking the ones that are the right ones to pursue to fruition. So none of this would have been possible without any of those folks, for sure. And I'm greatly thankful for all of their help and all of their support. So I think probably that's as far as what other advice I give folks is surround yourself with an excellent team, because that's the most important thing, is the structure and the support that you have. And I'm very lucky at MCHD EMS to have, clinical support, administrative support, community support for this. And it's really an excellent place to practice EMS medicine. And I'm very thankful for that, and thankful for you guys for having me on and to share this. If anybody out there has questions, detailed questions, my email's in the manuscript, but it's cpatrick@mchd-tx.org. So feel free to fire questions if you have any, or thoughts or criticisms or any of the above. I'd be happy to talk with anyone about our work or any of our ideas or anything that we talked about on the podcast here. So thank you, Joe, for having me. I really appreciate it, and hopefully the listeners enjoy.
Brilliant. Thanks again for your time, Casey. And thank you for those who are listening into the PDM podcast #1. Take care of yourselves out there, and we'll see you at the next podcast.